Welcome to the other side of Lucy Letby, a podcast that looks at the medical and scientific evidence used to convict the neonatal nurse of multiple accounts of murder and attempted murder. In episode 12, we're going to finish up with Baby B. Baby B was born on June 7, 2015, weighing 1,669 grams. Baby B was the sister of Baby A. Baby A died within 24 hours of birth. Before we carry on with Baby B, we're just going to look at a paper from Global Public Health published in 2021. It's entitled Causes of Death Identified in Neonates Enrolled Through Child Health and Mortality Prevention Surveillance, December 2016 to December 2021. So this was an analysis of 1,453 such deaths, and 41% occurred within 24 hours. Another 41% occurred within the first 7 days. So 82% of all deaths occurred within the first 7 days. And the leading causes of death were complications of interpartum events, complications of prematurity, infections, and respiratory disorders. Surprisingly, congenital malformations was only a cause of death in 8%. In addition to the underlying causes, 62% of deaths had additional conditions and 14% had more than 3 other conditions in a causal chain. The most common cause, considering the whole causal chain, was infection, prematurity, and respiratory distress syndrome. So you have to bear all that in mind when we're looking at Baby B and Baby A, and we'll reference this paper in the notes. So you remember that Baby B was born to a mother with antiphospholipid syndrome. We're just going to look at the defence. Mr. Myers notes that at birth, Baby B was blue and floppy with poor tone and a heart rate of 50. So Baby B was very poor condition at birth, despite what the prosecution said. No doctor would consider that a baby in good condition. Resuscitation efforts were required with a series of inflation breaths. Intubation was successful after a couple of attempts, and Baby B stabilised on the evening of June 7th. So we remember when we talked about Baby A that the registrar and nurse, the only 2 people present for the birth of twins, noted that Baby B needed more help than Baby A. And I disagreed that Baby B needed more help than Baby A, that both of them needed equal help. But because there was only 2 people there, they had to make a triage decision. If they worked harder on Baby B, there is a possibility that that meant Baby B would survive the pitfalls of birth. Whereas if they worked less on Baby A, that would increase the likelihood that Baby A would die. So look here then at the 8th of June, so that's the morning after Baby A and B were born. At 9:20, a message is sent to Lucy Letby asking her to split her shifts, and she replies, "Yes, that's fine, is it busy?" And the reply came, "We have 3 on CPAP, twins last night, wanted 6 staff on." So this was the neonatal unit heavily criticised by the RCPCH, and they've just had 3 30-week babies on CPAP. Could they really handle that kind of work? That would be busy even for a level 3 unit. So we know what happened to Baby A on June the 8th. Baby A sadly died on June the 8th. And you should consider the list I've just given you there of the common causes of death, and the 41% of babies die on the first day. due to birth asphyxia, and that's always a really, really big problem, completely downplayed in this trial. If a baby has to be resuscitated immediately after birth, they're at huge risk of death. So baby B, on the 9th of June, baby B's lungs were examined to be clear, and the baby was very alert and active on the morning of June the 9th. At 11 a.m, a weaning program note is made for the weaning of baby B off breathing support, so that's off the CPAP. So a further nursing note showed baby B was very stable after being weaned off CPAP and allowed time to be with baby B's mum. Baby B was in room 1, while Letby is assigned to babies in room 3. And we have to do away with this notion of you're only ever going to work with the babies to which you're assigned. People have to take breaks. People have to speak to parents. You work as a team, and particularly at night, you'll work as a team. You'll get second opinions. You'll ask people what they think, etc. You will ask colleagues to do things for you. The fact that a designated nurse isn't the one that's actually doing something in a neonatal unit is not unusual at all. And yet it's pointed out in this trial time and time again that Lucy Letby was taking care of babies that she wasn't the designated nurse for. That really doesn't mean anything. And any neonatal nurse or any doctor who works in the hospital, particularly at night, will tell you that that's the case. And the court hears one of Letby's colleagues is the designated nurse for baby B and another baby in room 1. So we have a baby on CPAP, and we know that that baby is an intensive care baby, but yet one of Lucy Letby's colleagues is looking after 2 babies, which is not what you should be doing. It should be one nurse for an intensive care baby. So following baby B's collapse, another nurse took over looking after the other baby in room 1. So we had to wait until the baby collapsed before the recommendations were put in place. Nursing notes written by the designated nurse, written in retrospect, and a lot of these notes are written in retrospect, found baby B's CPAP prongs had been pushed out of the nose. Oxygen saturation levels had fallen to 75% before midnight. This had nothing to do with Lucy Letby, nothing to do with the other nurse. Why was the designated nurse who was with baby B not suspected of pushing the CPAP prong out of the nose? CPAP prongs in the nose fall out all the time, and particularly nasal CPAP, that's continuous positive airways pressure going through 2 little prongs into the nose, has a very high failure rate, 14 to 40%, very high. So it's not unusual that a baby on nasal CPAP would desaturate at all. When the prongs were repositioned for baby B, after a little while the oxygen levels recovered, so that's very good. But it does show you that baby needed CPAP, and without CPAP she would deteriorate very rapidly, and she would take a while to recover. And the heart rate was stable. There was good respiratory effort throughout. So the respiratory effort throughout means that baby B was breathing herself. She was initiating the breathing, and the CPAP is merely supporting the breathing. And she was observed to be stable prior to midnight. None of this really matters, whether she's stable or whether she's not. She's just a newborn baby, preterm, with a lot of problems. She can desaturate or stop breathing at any time. So on the 10th of June, Letby's then involved with administering nutrition to baby B at 5 past midnight. And Letby is the co-signer for the nutrition prescribed at 12:05 on June 10th. A blood gas record by Letby of child B is made at 12:16. And another, what appeared to be 12:51, the latter was during neo-puffing. And at 12:30 a.m, so that's 14 minutes after Letby did a blood gas, the designated nurse records the desaturation and collapse event at 12:30, written retrospectively includes the notes sudden desaturation to 50%. Colour changed rapidly to purple blotchiness with white patches. Emergency call put out for doctors. A fast bleep alert for a nurse to attend the neonatal unit as soon as they can is made at 12:33. This is what the evidence is reported from court. Following emergency treatment, baby B was placed on a ventilator and good air entry was noted. The baby was put on a ventilator, not CPAP, and this was a baby, remember, that they had tried to wean off CPAP earlier that day. We have to bear in mind that weaning off CPAP for a preterm neonate can be risky. Weaning can result in respiratory instability and atelectasis, which is a kind of lung collapse. There are lots of strategies for weaning off CPAP, and one of the ways that you do it is moving to high flow nasal cannula, and that seems to help. But this baby's already on nasal cannula. Baby B's colour started to improve almost as quickly as it had deteriorated. So what does that tell you? Well, that tells you that as soon as you put back the oxygen, restore the oxygen exchange, the purple colour, which I've described before as mottling, improved. And this is what you see all the time. You see mottling coming on very quickly and hopefully going away very quickly, because it's a kind of instantaneous response of compensated shock where you're shutting down the peripheral circulation so that you can force more blood to the centre. And each heartbeat then is more effective in that type of situation. So nothing unusual here at all. Baby B was also noted from a note at 12:45 to have a full, mildly distended abdomen. Nothing unusual at all about that on a baby who is on CPAP. At 12:51 a.m, blood gas recorded by Letby of baby B is made. 1 a.m, Letby is recorded taking the hourly observations at 1 a.m. for baby B in room 1. And then the prosecution reminds the court that Letby was the designated nurse for 2 babies in room 3 at the start of her shift. Now we have to remember as well that the babies in room 3 are less needy. It wouldn't be unusual in the case of an emergency that the nurses would group together, or the doctors and nurses would group together to deal with that, and they would leave less qualified people to keep an eye on the babies in room 3 and room 4. A note timed from 1:10 in the morning from an X-ray said that baby B's lungs were mildly hyperinflated and clear. So you can be pretty sure if the lungs are mildly hyperinflated, the abdomen is likely to be hyperinflated too. The connection between the stomach through the esophagus and the airway through the larynx is extremely close. Positive pressure, it's being applied across both of them equally. So air is going to get forced into the stomach and into the gut, and that is what's called CPAP belly. It's very, very common. Further medication is administered to baby B. Baby B was also given morphine, and Letby was again listed as a co-signer. So it seems as if Letby and the designated nurse were working as a team with this baby. That's what it would read like to me. So at 2:40 a.m, the purple discoloration had almost resolved, and nobody knew what the cause of it was. So when you say you don't know what the cause of it was, doesn't mean you don't know what it was. So mottling, what was the cause of the mottling? Well, the cause of the mottling was a collapse, but you don't know what the cause of the collapse was. No one is going to be particularly worried about mottling that is resolved, because it means you've resolved the underlying problem. Then at 8:10 in the morning, a nursing note made by one of Letby's colleagues, June the 10th, records obviously that the family were very upset about the collapse at 12:30. And a colleague said the shift had been manic and there had been no change in baby B, but the shift was manic. What does that mean? Letby inquired again about baby B that night at 10:08 p.m. and was informed baby B was looking really good. A message from Lucy Letby on WhatsApp to a colleague at 12:04 p.m. included the request, "Will you let me know if there's any change in baby B?" Why would a doctor or nurse do that? Particularly when you're dealing with the resuscitation of a patient or something very intensive, and then your shift comes to an end. Most of us, particularly when we're very young, we don't forget that. And we want to know what the outcome was. So it's not unusual that you had asked your buddy or your mate or your colleague or whatever to let you know what's happening, because you're now off shift, but you may not be on shift for a couple of days. You want to know what's happened. So again, there's nothing unusual in this at all. A text message at the end of June from Letby said, "I had a mini meltdown last night about what happened at work. I just needed some time off with mum and dad." Well, boy, do I know about that. When you're involved with these things, you have to be very focused. You have to be very professional. You cannot show any emotion. You have to suppress all that. But it doesn't stay suppressed. For most of us that actually care about patients, it doesn't stay suppressed. It actually surfaces when you become very frightened, and all of the emotions that you didn't show at the time come bubbling back to the surface later on. So wanting to be with people that you love, wanting to be away from the whole situation is, again, very, very normal. And this message was sent following the deaths of baby A, baby C and baby D, and the non-fatal collapse at baby B. So this was something that Letby and all the other nurses, over the space of a few weeks, this had happened to them. So they're all going to be pretty shell-shocked if they occur at all. On the 9th of June, at 9:58 a.m, Letby searches on Facebook for baby A's mum. And the 10th, Letby is recorded making another search on Facebook for the mum of baby A and baby B. And again, at 11:31 p.m. on June the 10th, the 25th of June, the 2nd and the 9th of September, Letby made further searches for baby A and baby B's mum. Again, I don't condone this stuff at all. I find that anything to do with the patient is an invasion of privacy, that you can only interact with the patient with their consent, no matter what it is. If you said to the mum, or you said to the family or whatever, "Do you mind if I check your Facebook page just to see how you're doing?" Something like that. That would be okay. But if you don't tell them, I don't think this is very professional at all, and you couldn't really defend that type of behaviour from an ethical point of view. But this is the modern world of social media, and it must be difficult for these younger people. I don't know, but I don't regard it as being particularly ethical to do that. But it's noteworthy, Ms. Hocknell, so this was the police officer, is asked by the defence about Lucy Letby's Facebook searches. And she is asked whether Letby searched on Facebooks for parents of children other than those listed in the charges. And Hocknell confirms that is the case. There are lots of searches for different people. So what does that tell me? Well, that tells me that Lucy Letby was a habitual Facebook searcher, but she wasn't just searching for babies that she supposedly harmed. She was searching for lots of different people, according to the police. So I think that really diminishes the evidence that she was looking only at the babies that she allegedly harmed. And among the evidence were clinical records and charts, swipe data showing who had access to the neonatal unit. But we now know, of course, that the swipe data was incorrect. And that in itself, because the swipe data was used as a big part of the evidence against Letby, that should result in a mistrial, in my humble opinion. On Letby's phone record through Facebook searches, blah, 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 Letby says she didn't want to see BBA's parents. And to another colleague, I think we did everything we could under very difficult circumstances. That reminds me of an incident I was involved in a long time ago. Unfortunately, it was the death of a young child in a traffic accident. And I sat with the mother in the accident and emergency department, held her hand, listened to her crying, everything, and tried to listen to her the best I could. And I can tell you, when you're not really experienced, doing something like that is very, very difficult. But the worst thing of all was when I was getting up to go and leave the mum, she picked up a little red shoe, which I'll never forget. And she handed it to me and she said to me, "Oh, here, bring that with you. She's going to need that when she comes home." So the mother didn't hear a single word I said. And when I went back to the mum again 4 or 5 hours later, I didn't really want to go back to that mum at all. I didn't know how to speak to people. I didn't know any of that stuff because I wasn't experienced enough, and neither was Lucy Letby. And they go on to say, luckily it doesn't happen very often here, not that that's a consolation. Letby said that the night shifts had been the hardest thing she'd ever had to do. All of this stuff, perfectly normal, perfectly run-of-the-mill, everyday hospital stuff. PBB, preterm baby, could suffer a non-fatal collapse at any time. It's the prosecution case that Letby injected air into baby A and B to cause the collapses. The defence deny that happened. To me, this is just absolute nonsense. There's really no evidence for this at all. An interesting exchange that goes on here. At the start of her night shift at 8 p.m, Letby texted a colleague, "Just a big shock for us all. Hard coming on tonight, seeing the parents again. Don't blame her." In a separate conversation with a nursing colleague who had been looking after baby A prior to his death, she informed the colleague the baby had died. And Letby replied, "It was awful. He died very suddenly and unexpectedly just after handover. Not sure why. It's gone to the coroner." The colleague, "Oh God, he was doing really well when I left." And Letby said, "I wasn't supposed to be on that night either. The boss swapped my nights because the unit was busy. But these things happen, unfortunately." Letby's colleague, "Yeah, it's the business we are in, unfortunately. Hopefully baby B will be okay in the end." And you note that she says hopefully, because you cannot tell. You do your best, but you can't tell. On June 30th, following the death of baby A, C and D and the non-fatal collapse of baby B, Letby's colleague messaged her there was something odd about what had happened. Letby replied, "What do you mean? Odd that we lost all three in different circumstances?" And Letby's colleague responded, "I don't know. Were they that different?" You have this nurse saying something odd. So what does something odd mean? Something odd is a vague sense of something. You lose 3 babies when you're not used to losing babies at all. That's odd. Of course it's odd. Were they that different? So that's a question. She doesn't know either. The colleague adds, "Ignore me. I'm speculating." So she's speculating. And I think the speculation continues to this day. The court also heard that Letby had gathered a lot of her handprints and footprints for baby A after he died. This is actually routine, standard stuff. Again, nothing unusual. Nursing notes at the time recorded the family were too upset and bereaved to accept the memory box initially, and were advised they could take the box to keep when they were ready. Messages also show nursing colleagues had praised Letby for how she had managed during her shift the night baby A died. One told her, "You did amazing, so proud of you. don't mean to sound patronising, that's genuine. So this is what these people thought of this murderer, and we've just gone through a lot of kind of general stuff because there's not much information on Baby B in the public record, really, to show that there's nothing unusual or anything that's going on here at all. It's interesting as well that they said that Baby A remained in an incubator known as a hot cut for the next 2 hours as arrangements were made to take him to Alderhead Children's Hospital, Liverpool, for a post-mortem. So the fact that the baby is kept in an incubator, any gases and air and stuff found in the body after death is likely to be affected by the incubator temperature. And that should have been explained to the jury. Some consultant unnamed for Baby A and Baby B, she can't recall the events for Baby B's collapse on June the 10th, as it was 7 years ago. So there we go. Her recollection would be based on the statement she'd given to the police. The court is showing clinical notes made by her retrospectively at 2:40 a.m. on June the 10th, 2015. She was called at home at 12:36 and she arrived at the neonatal unit at 12:50. So very fast, 14 minutes to get to the neonatal unit, but it's still 14 minutes. Dr. Jairam probably took 14 minutes at least to get to Baby A. So what he witnessed with Baby A cannot be what Dr. Harkness witnessed. She recorded Baby B went apneic, stopped breathing, followed by sudden purple blotches all over the body with a slowing of the heart rate. The consultant says the purple blotches would have been the registrar's account of events related to her. So that's very similar to Baby A, except in Baby A's case, Baby A did not recover. The registrar also relayed child B was bagged and tubed and the heart rate went up and adrenaline was not required. The consultant noted for her observation, upon my arrival, purple blotching right mid-abdomen and right hand. Baby was pink and active. The prosecution says, do you have any independent recollection of that now? And the consultant replies, no, because it's not particularly unusual or particularly striking, or what was the word that Professor Kinsey used, impactful. It's so unimpactful that this consultant has no memory of it. The consultant relays the various medical observations that were recorded at the time, including blood gases, protein levels, and heart rate. The consultant tells the court discussions had been going on since the evening of June the 9th, in light of Baby B's twin brother dying, on whether Baby A or Baby B could have been affected by the mum's blood condition. And consultants at Great Ormond Street Hospital had said they did not feel the mother's condition would affect the baby in any way. But consultants at Alderhead Hospital suggested that further blood tests be carried out. Requested extra tests were held off. Baby B was restarted on antibiotics as a precaution. So Baby B was put back on antibiotics. Could that have made a difference? Yes, it could have. There was still concern her recirculation had to return to normal. So the consultant noted more fluids were administered to help with that. So here we have a situation where the consultant is ordering more fluids for a baby to restore its circulation. Yet we're told that the lack of fluids in Baby A would not have had an effect on the circulation. So those two things don't really add up to me. The consultant notes she spoke to the parents. The purple coloration had resolved and she didn't know what was the cause. So she didn't seem unduly worried about it either. The consultant says, from looking at her notes, she was quite puzzled by that, as there were 2 question marks. The note adds, stabilised at present. So the consultant quite rightly realises that Baby B is more stable only at present. There's no guarantee it's going to stay that way. And continued antibiotics, nil by night, mouth, Repeat gas and wean as tolerated. The note concludes for further tests to be repeated at 7:30 a.m. at the end of the night shift. So we have a mystery desaturation. Ben Myers, KC, for Letby's defence, asks about one area on the clinical notes. Mr. Myers asks about the purple discoloration and that by the time the consultant had arrived, she had noted what she had seen at 12:50 a.m, so that's the 14 minutes after she was called, and had almost resolved by the time of the note of 2:40 a.m. She tells the court, "I think this was something I was puzzled about and wondered what it could be." But she's not offering any opinion, even now, as to what it was or what it might have been. She says other causes were ruled out, as such a rash had come out of nowhere and had almost completely gone a couple of hours later. Well, it's not a rash. Again, I've talked about that. It's a discoloration. It's not a rash. A rash is a lesion on the skin, and this is not a lesion on the skin. She added she was a little bit confused, was trying to put in place all that was safe for baby B. Right, so then we get to Professor Arthur's. For baby B, the radiograph image shown from June 10th, around 40 minutes after the time of non-fatal collapse. And Myers said, on that image, there are no features which support a neuroembolism diagnosis. And Professor Arthur says yes. So we have no evidence whatsoever of a neuroembolism in baby B. That doesn't mean there wasn't a neuroembolism, because baby B was on CPAP, but we have no evidence of it. He clarifies from a question by the prosecution that it could not be concluded either way. So how can you go from there's no features on an X-ray to support the diagnosis of neuroembolism? That is a definitive statement that he has agreed with. And then he equivocates by saying that you can't conclude it either way. If you can't conclude something in medicine either way, you have to say it's not there. You have to know whether it's there or whether it's not. Then we get to Dowie Evans. He said the collapse was not really likely as all the markers were satisfactory. The medical staff had felt comfortable enough to allow the baby girl to be out of the incubator for a short time so she could be handled by the mum. He said that was not something you would do if a baby was not stable. He said the conclusion he had for baby B's collapse was smothering or an embolus. The discoloration was a striking feature which had been seen in baby A. So we have this whole story continuing on. In the appeal court, the judges said that the rash was not the only thing that was used to determine whether baby had an embolism or not. But it's heavily used here, and it doesn't mean anything. So getting to cross-examination, Dr. Evans agrees with Mr. Myers that a baby like baby B is prone to desaturations. Well, there we go. Mr. Myers presents a clinical note to the court from June 19th, 12 days after baby B was born, noting there were desaturations recorded, if not on the same scale as those recorded during the non-fatal collapse. Remember, the collapse was non-fatal. It was a desaturation that responded very quickly to resuscitation. And on June 20th, when the apnea alarm went off on 3 occasions, the oxygen saturation went down to 70 to 80% in each occasion. So baby B continued to be at risk of desaturation and at risk of collapse, even 10 days after the so-called incident. A pediatric assessment dated July 14th for baby B presented to the court, in which breathing problems are noted along with mottling. Over a month later, she was still having breathing problems. Pediatric assessment dated July 14th for baby B presented to the court. Breathing problems are noted along with mottling, which is the exact description of what happened on June the 10th. And this is nearly over a month later. Mr. Myers, there are respiratory issues associated with her health. Then we have Dr. Evans. Nothing compared to what we would call the index event, the collapse. She needed resuscitating. She was also 4 weeks younger than she was in July. So would you expect a baby who has survived for another 30 days or more to be more robust than one at 31 weeks? Of course you would. Mr. Myers asked about the differential diagnosis for baby B, concluding there was either an air embolism, suffocation, or someone had removed the prongs on purpose. Dr. Evans said his opinion he was on the ball from the start, considering an air embolism. Of course he was. He adds that baby B recovered, and that is inconsistent and contradicts the air embolism theory. So this is Myers saying this to Evans. Dr. Evans said, no, it does not. We cannot do studies where we inject air into babies and see what happens. So Dr. Evans is saying that we have no body of evidence, no body of knowledge about air embolisms in babies. But he has sufficient knowledge to draw these exacting conclusions where he's giving absolute amounts that Letby gave, timings that Letby gave, and he's able to say that one baby recovered and the other baby didn't recover, but that's perfectly all right, even though we have no experimental evidence to form the basis of that opinion at all. He added that the volume and speed at which the air is injected along the scale of the resuscitation attempts can make a difference as to whether the baby survives or dies. Well, we do know from, again, we say from the Shuley paper, which talks about pulmonary air embolism, which is different than venous air embolism. We do know that 2 of the babies survived. We know from another study of 25 babies that had venous air embolism, 1 survived. So it is a very fatal condition when it's detected in preterm neonates. Dr. Evans says under questioning by Mr. Myers, he would be happy to hear an alternative explanation from a medical perspective for baby B. But he is happy with the conclusion that he made for baby B, that she had had an embolism. The prosecution refers to a clinical note in June the 20th. Following the desaturation recorded, the note adds baby B self-corrected. And Evans said, it's a bit frightening, but she self-corrected. These things happen in babies. Yes, and as they get older, they happen less. Dr. Sandy Bowen is now giving evidence in respect. She confirms case notes, photographs of baby B, and peer-reviewed doctor who have been here before. She says baby B was compromised at birth and required respiratory support, which was not that unusual for someone of her prematurity. She stabilised very quickly, Dr. Bowen added, and was in air with normal blood gases and stable enough to have skin contact with her mother and for feeds to be started. Dr. Bowen said the circumstances of baby B's collapse were not normal, but very concerning. She said despite being on CPAP, she was otherwise normal. Let's just have a look at another paper here. So this is in a journal called Transitional Stroke Research, and it's entitled Sudden Unexpected Postnatal Collapse of Newborn Infants. So could we say that baby B was subject to a sudden unexpected postnatal collapse? I think we could. So this was a study aimed to review available publications concerning sudden unexpected postnatal collapse, which is also known as SUPCs, of apparently healthy infants within the first days of postnatal life. They have found 398 published cases of SUPC occurring during the first postnatal week. Estimated incidence of SUPC of presumably healthy infants after birth differs widely, ranging from 2.6 to 133 cases per 100,000. In other words, the incidence is not really known. However, definitions, inclusions, and exclusion criteria vary substantially between reports. Our summary indicates that reported SUPC occurs more frequently than expected from recent surveys. About half of the infants die, and of the remaining survivors, half have neurological sequelae. Of 233 cases of sudden unexpected death described, no etiology was found in 153 cases. When a defined time for SUPC event is described, approximately 1/3 of reported events occur during the first 2 hours, between 2 and 24 hours, and between 1 and 7 days after birth. So, sudden unexpected postnatal collapse of apparently healthy term or near-term infants within the first days of life is rare, but can have catastrophic consequences. We're talking about term babies here, not preterm babies. Term healthy babies that can suddenly collapse and die, and we don't know why. SUPC includes both severe apparent life-threatening events, also known as ALTE, and sudden unexpected death in infancy, SUDI. Sudden unexpected early neonatal death, or SUEND, shares features with SUDI, but is not included in SUDI, which is limited to post-perinatal deaths 1 week to 1 year. 400 published cases. It goes on to say, even if several of the unexpected deaths can be explained after autopsy, 153 described SUPC cases leading to death remained unexplained and have been classified as early sudden infant death syndrome. Well, one of the things they did find was a mild inflammation in the brainstem, which involved the cardiorespiratory control area, and that was found in 7 of 9 cases examined by one study. More inflammation was found in 10 out of 16 cases in another study. People need to look at this paper in the light of what Dr. Evans and Dr. Bowen said, that sudden desaturations don't happen in preterm neonates. The nurse that was on with Letby the night that baby B collapsed confirmed that Letby was with her when the collapse occurred. So the collapse occurred 15 minutes after the baby had a blood gas checked by Letby. But Letby was not present with that baby when it collapsed. She was with the other nurse. So he talks about the amount of air that gets in over what period of time, etc. But in Letby's case, he claims that Letby gave all the air at once. So there is none of this slow build-up of air that eventually goes to causing air embolism. All of it went in at once. If Letby gave 5 mils of air at once and it was going to cause collapse, it would cause collapse immediately. It would not cause collapse 15 minutes later or 20 minutes later, the slow fuse theory that Evans says. I don't think Dr. Evans gave an adequate explanation for how he came up with this theory. And I don't think the medical literature supports any of the assertions that he made. So that means that we really don't have any evidence whatsoever that baby B had an air embolism. And yet Lucy Letby is found guilty of giving an air embolism. I don't think it's possible. We're not going to dwell much more on baby B. Thank God baby B survived its ordeal. And I will leave links to articles on venous air embolism, which is different than pulmonary air embolism, and they don't make any reference in general to skin discoloration. So I think this whole thing, this skin discoloration thing, has to be cleared up by neonatologists and people who practice this type of medicine on a daily basis. In the next episode, we're going to look at another podcast on YouTube by two lawyers, actually quoted me, and I'm going to point out why they are so wrong in the things that they said. So we'll see you then. Bye.